Morning, Anna.
Today we're talking about glomerular disease. Hi, Jen.
Hello, how are you?
Hi. This is a subject that I actually found really challenging because there's new consensus statement. It's not new, it's like 2013, but as I was studying for my fellowship exams, the way we think about glomerular disease was completely shifting in sort of categories and things. And then my first time I sat the fellowship exams, I got a question, a really, really detailed question on, like, they literally put up a histo picture without the report and said, interpret this and essentially diagnose it. And it freaked me out and I lost all of my knowledge on glomerular disease. And then the following year, I was like, well, they're not going to ask that again. So I never studied it again. So I saw this topic come up and was like, oh, triggered. So I'm grateful that you guys have provided the opportunity for me to go back and desensitize myself to glomerular diseases. It is a really complex structure. And in Edinger, I've sort of done the subjects out of Edinger in the order they come up in the book. And I probably would have instinctively done glomerular disease before tubular disease and acute and chronic kidney injury, just because it talks about the beginning of the kidney's function in terms of filtration and then resorption, excretion being the tubular function sort of thing. And it's helpful to know glomerular anatomy when you're talking about chronic kidney disease and acute kidney disease. But I'm going to try and stick just to glomerular disease. But if you want to bring in some questions and stuff as to how glomerular disease causes acute kidney injury or chronic kidney disease, please just chuck them out there. Josh is on externship, so he can't attend for the next 2 sessions. So I'm not going to specifically pick on anyone unless they ask for it.
We'll be quiet.
Sorry, Jeff?
I said we'll be quiet.
I thought you were putting your hand up.
No.
But I do want to make it as interactive as possible. The first thing I think is really good to just get your head around is glomerular anatomy. Did anyone have a chance to do any reading before this? No. Essentially the glomerulus it's like a big sieve, and its job is to filter blood coming into the kidney. As you remember from the previous kidney series, the glomerulus is the first part of the nephron, which is the functional unit of the kidney. And when we get any glomerular injury, it's going to impact the tubule, because what's filtered through the glomerulus will be abnormal. So the ultrafiltrate will be abnormal. And if we get any damage to the blood supply in the glomerulus, so the blood supply comes in, this is a really important concept. Blood supply comes in through the afferent arteriole, sits in that little kind of capillary bed of the glomerulus, and then goes out through the efferent arteriole, which then becomes the vessel that provides blood supply to the whole nephron. So if we get an obstruction, if we get hypertension, if we get damage to the endothelium in the glomerulus or efferent arterioles, we're going to cut off blood supply and lose the entire nephron. There's this interconnectedness between glomerular health and nephron, entire nephron or tubular health. As we talked about with chronic kidney disease, anything that causes swelling so in the interstitium, outside of the tubules or glomerulus, will put pressure on those structures, including the blood vessels, and that will alter both blood supply and flow and ability of the nephron to function. I started doing some arts and crafts before you guys joined. So I just want to sort of talk through the different layers of the glomerulus and the anatomy and try and make this make sense. And there's really good YouTube videos on Arnando, the guy who did the tubule video that the physiology video that I showed, has done the glomerular one. That's excellent. If anybody kind of sees me do this and goes, oh, that doesn't make sense. So essentially going through that anatomy again, we have blood supply coming from the heart. 25% of the blood supply from the heart goes to the kidneys in dogs and cats. A huge proportion is going through the kidneys. So then 100% of the blood comes into the afferent arteriole and then sits around in here. So you can imagine the blood pressure coming in here is pretty much equivalent to the systemic blood pressure, but we've got autonomous control over the afferent and efferent arteriolar diameters. Can anyone explain to me what I mean by that? We'll explain to everyone what I mean by that.
The kidneys controlling the, I suppose you could loosely say the sphincters on both of them.
Yeah.
To alter the flow and the pressure.
Exactly. Yeah. So if we've got dehydration, what's going to happen to the blood flow to the glomerulus?
Be decreased, of course.
Be decreased. Yeah, exactly. So if we're dehydrated, we don't want as much blood. Oh, that moves around a bit. We don't want as much blood being filtered out into urine, do we? And we've always got the backup option of reabsorbing it once it gets to the tubule. So we need to keep some blood moving through there, but we don't want as much blood moving through there. So we're going to get vasoconstriction of the afferent arteriole. What about if we've got a blood pressure of like 170? What's going to happen to the afferent arteriole?
It'll be constricting, wouldn't it?
It constricts, exactly, because it doesn't want to let that hypertension through to blast this really fragile fenestrated endothelium of the capillary, the glomerular capillary bed. At what point of blood pressure does that overwhelm the kidney's ability to auto-regulate that?
Is it 180 systolic?
Yeah, 170, 180. So above that, the afferent arteriole just can't protect the glomerulus from damage, and that blood pressure gets through and causes endothelial damage. What about if we're really volume overloaded, we had a really salty meal, what's going to happen to what's going to happen to the glomerular pressure, the hydrostatic pressure in the glomerulus?
It will increase because you have drawn more fluid into your circulation.
Exactly right. Good. So we've sort of talked about different ways that the hydrostatic pressure in the capillary bed might be impacted. What other forces? So say 100% of the blood comes through here, 80% goes out the efferent, and 20% goes across into the to be filtered, goes into the tubule. What other forces are determining movement of fluid across that filtration barrier? We've got hydrostatic.
Oncotic pressure?
Good. Oncotic pressure, excellent.
And then like the cell lining itself, like
yes,
the integrity of the cell lining.
Exactly. So the resistance to flow. So if you think about running fluid through a sieve with really tiny holes, the fluid builds up more because there's more resistance, as opposed to running fluid through a sieve with big holes, it flows really easily. So the three things that determine or that impact how much blood gets filtered into, or how much urine is produced essentially in the proximal tubule, is hydrostatic pressure, which is the big one, oncotic pressure, and then the third one is the resistance to flow, and that's provided by this basement membrane here. So if I was to tell you, the endothelium is really specialized in the capsule here, in that it's fenestrated. So there's little slits in it. Those slits are, I'm going to cheat, 70 to 100 nanometers in size, the holes in the endothelium. A red blood cell is 10 micrometers. So if we've got 100 nanometers versus 10 micrometers, a red blood cell is 10 times the size of that hole. So the blood comes in, it swims around. Are red cells going to be going through those holes?
No,
And given white cells are bigger than red cells, are they
No.
going through those holes? No.
they're bigger again.
Exactly. But pretty much everything else, solutes and proteins, are smaller than the diameter of those holes. So this endothelium provides a barrier only for cells. Pretty much everything else, depending on hydrostatic pressure, will move into this second sort of level of filtration, which is the basement membrane. What properties does protein have? So basement membrane is made up of protein, it's fibrous tissue. What properties does it have which would provide some sort of filtration?
Well, are there electrostatic?
Great.
properties?
Yes, excellent. What charge is on fibrinous membrane? Positive or negative?
Positive.
Who said something? 50-50. It's negative.
Negative. Mhm.
Yeah. So protein has a negative charge. What happens if you put two magnets together, negative end to negative end?
Well, they repel, don't they?
They repel, exactly. So if we've got protein in our capillary space and we've got protein here, is the protein going to want to move towards the protein? No.
No.
Exactly. They're going to repel each other. So that's one of the mechanisms that we can keep protein in the vascular space. Little bits of protein will still get through, but they'll be either stopped by the podocyte, by the epithelial barrier, or they'll be reabsorbed in the tubule. So we've got an electrostatic barrier in the basement membrane. And then the third layer of filtration is provided by an epithelial layer. So if you think of like the walls of a blood vessel, we've got endothelium, we've got the kind of extracellular matrix sort of thing. And then on the other side of that, we've got an epithelial layer, which is made up of podocytes. What does pod mean in as far as origin of word?
Little feet.
Foot.
Little foot, exactly. Yeah. So these are cells that have little feet that come off them. And those feet just stomp all over the basement membrane, cover the whole basement membrane. And they provide an even smaller filtration barrier, which is, so if the one in the endothelium was 70 to 100 nanometers, this one is 10 to 40 nanometers. So nearly a tenth of the size. And that provides a barrier for, this is a really important clinical question. So we've got the basement membrane blocking some of the proteins. Say albumin and globulin get through. Which one's bigger of those two?
Globulins.
Globulins are bigger, exactly. Globulins are too big to fit through this podocyte holes. So albumin, little bits of albumin can get through, only little bits because we've got that electrostatic charge as well. But globulins should never be found in the urine. In what situation clinically do we sometimes see globulins in the urine?
Are you talking about specific condition?
Yeah.
Myeloid, Bence-Jones proteins.
Yes, good. What about Bence-Jones protein?
They are found in myeloid. What's the word? Myeloid. Myeloid looking. Multiple myeloid looking. I think that.
Multiple
Yeah.
myeloma.
Multiple myeloma. Yeah.
Which is a cancer of which cells?
I think myeloid cells, like so, granulocytes and is it?
Mast cells, isn't it?
Not mast cells. What are the cells that produce globulins?
Oh, like beta cells.
Plasma cells. Exactly. So we've got the plasma cells producing globulins, and we've got clonal what's the word for making lots of cells?
Like gammopathy, is that fully?
It's like the plasma cell. So we have one plasma cell that got mutated and then it cloned itself a million times. So all of a sudden we've got 1 million plasma cells producing the same globulin. So we get what we call a monoclonal spike on our plasma electrophoresis because they're all the same. Now, if that plasma cell happens to be producing just a section of an immunoglobulin rather than a whole immunoglobulin, it might be small enough to sneak through here and end up in our urine. And that's what Bence-Jones proteins are. They're segments of immunoglobulins. Now, if we had a patient and they had an albumin level of 13, they were edematous and azotemic, or no, sorry, non-azotemic, I'm going to say, but the globulin level was high normal. Our two big differentials are protein-losing enteropathy and protein-losing nephropathy. The normal globulin level is the thing that differentiates these two conditions. Because in the abdomen, you're going to lose globulins via the in the enteropathy, you're going to lose globulins via the lymphatic vessels. In the kidney, you should never be able to lose globulins. There's too many barriers to filtrations for globulins, even with some glomerular damage. Okay, does that make sense?
Yes.
Yeah.
Anatomy-wise?
Yes.
Good.
Good,
And we
great
know
explanation.
exactly what happens once the ultrafiltrate gets into the proximal tubule because we've already covered that. So we don't need to go any further with that. So the only other cell I'm going to talk about in here is called a mesangial cell. Now, the mesangial cells sit on the blood vessel side of this barrier. So where the basement membrane is kind of the fibrous layer outside the blood cells, in these little gaps, there's these mesangial cells. Now they're important and they sit in this extracellular matrix, but these mesangial cells are important because they produce factors which cause constriction and dilation of the glomerular vessels. So they can actually contribute to blood flow through the glomerulus. And in certain glomerular nephropathies, we get inflammation of the mesangium, the extracellular matrix on the blood vessel side of the filtration membrane. And that differentiates it from other forms of glomerulonephritis where we get inflammation on the epithelial side of that basement membrane. So that's the only sort of significance. I keep saying mesangial, and then in the process of preparing for this, I watched a video and somebody said mesangial. Does anybody have an opinion about that?
I like your pronunciation better.
The first
Cool.
one for sure.
Yeah, agreed.
We'll call it correct.
Yes,
Yeah,
it's the Australian
definitely.
way.
Well,
Yeah,
well,
the other way sounds terrible.
as an English friend of mine used to say, whose bloody language is it anyway?
Sorry, say again, Jeff. Oh, I missed that. Sorry, Jeff. Okay, so we'll just stick with mesangial, but I'll acknowledge that I might be wrong on that one.
Yeah.
Anything else we need to cover about that? So given that we're really familiar now with the anatomy of the glomerulus, what clinical signs might we see in a patient with glomerular disease?
Protein loss, biggest, like
How might that manifest?
proteinuria. You check the UPC and it's really high.
Yep. Excellent. Any other clinical signs? What might the owners notice at home?
Oh, pitting edema, perhaps.
Good. Anything else?
Or thirst, I suppose.
Yeah, good. PUPD. What about on our blood tests? What are we going to see?
Azotemia, perhaps.
Yeah. Are they always azotemic?
Not always.
No, exactly. Yeah. What about on our biochem?
But that's a syndrome. Like if you're seeing high cholesterol and then yeah, that's a nephrotic syndrome. We don't like is that progression like a lot, or is that a subset?
It is sort of a subset, but it's not unusual to see hypercholesterolemia because there's protein loss. We get upregulation of the protein generation in the liver, and that includes lipoproteins, which increases cholesterol. So if we've got significant protein loss, we often have hypercholesterolemia.
Are you talking about Fanconi syndrome there?
Oh, I don't think it's Fanconi. I think it's nephrotic syndrome, actually.
Oh, nephrotic.
Nephrotic syndrome,
Sorry,
yeah. Which
I'm
is
just
just
getting confused in my old age.
Fanconi. That was in the tubular one, Fanconi syndrome.
Oh, that's right.
Yeah.
Renal tubular acidosis.
Yeah. So nephrotic syndrome is this kind of constellation of clinical signs, including hypoalbuminemia with the proteinuria, high level proteinuria typically, hypercholesterolemia, and edema or ascites associated with decreased oncotic pressure. And it's interesting, these dogs are often their albumins, like we see dogs with protein losing enteropathies that don't have peripheral edema when their albumin's 13. And these dogs still have globulins in circulation. They shouldn't be edematous, but they are. And that's part of just the sort of nephrotic syndrome, even when the albumin's not quite as low.
Do you have to have all four to call it nephrotic syndrome, or can you have three and then you can still call it nephrotic syndrome?
I think if you've got the hypercholesterolemia and systemic hypoalbuminemia, you can call it nephrotic syndrome. The edema's more rare, and sometimes I think animals hide it better than humans do.
Thank you.
What about on our urinalysis? What might we see on our urinalysis? Proteinuria, we've talked about.
You might see some casts.
Good.
Some hyaline casts,
Very
excessive
good.
hyaline casts.
Excellent, Bron. And then because we know that protein perpetuates renal damage or tubular damage, what other casts might we see?
Granular cellular casts.
Yeah, perfect. So as we get that tubular damage secondary to proteinuria, we get infiltrates of inflammatory cells and sloughing of the epithelial cells, tubular epithelial cells, and that forms granular casts which block the tubules as well. What about the USG?
It should be dilute. I would expect it to be dilute, unless you are losing glucose. If it's whatever, that's a tubular disease. Yeah, it should be dilute.
Yeah.
1.008 to 12, isn't it?
Sorry.
1.008 to 12.
So which part of the kidney is responsible for concentration of the
Yes,
Tubules.
tubules?
tubules.
Yeah, it's more tubules and medullary interstitium. If you've got early glomerular damage, should you have retained concentrating ability?
Yeah.
Yeah. So before you get the kind of then tubular damage and interstitial changes, you will probably actually have normal concentrating ability. So only 29% of dogs with glomerulonephritis have isostenuria, and 37% of dogs are over 1.035. So quite normal urine concentration. So it can be hard to pick, actually, even when they're azotemic. Yeah, so you see an azotemic dog with a normal urine concentration, you say, oh, that's pre-renal, don't you?
Yeah.
Yeah. But if there's protein, it's significant.
Would you get asked if you didn't have proteinuria? Like, Should we be doing sediment exam on every single sick dog, or just only this protein?
It's actually a really good question. If you don't have proteinuria, you won't get casts.
Yeah.
And you probably don't have a glomerular nephropathy if you don't have proteinuria. So it doesn't matter. But how reliable is a dipstick to detect proteinuria?
Not very reliable.
Not very, yeah.
Not reliable if it's the pH is not neutral and if the sample is dilute.
Yes, particularly if it's dilute.
Concentrated becomes more reliable.
It does, but we almost always get positives on concentrated urine, don't we?
Yeah.
Yeah. So it does make it harder to determine how relevant it is because it's so concentrated that those tiny little bits of protein that got through are now flagging on our dipstick. So we get both false positives and false negatives on dipsticks. Microalbuminemia won't show up on a dipstick, and that's particularly evident in dilute urine because sort of the per mil protein volume isn't going to show up. And Bence-Jones proteins won't show up either, but that's quite a specific syndrome.
I can't remember, is microalbuminemia just small amounts of albumin?
Yeah, it is. Yeah. So essentially, it's kind of a UPC in the range of like 0.5 to 1 sort of thing.
Right.
So
There used to be a direct test for that, wasn't there? Like an in-house. Is that still?
I don't know about in-house. They just we've asked for microalbumin and testing at Vetnostics before.
Right.
But yeah, typically the UPCR will suffice. Really, it's if I had a dog, for example, that was bred from parents who had a familial glomerular nephropathy or something like that, I would maybe start screening for microalbuminemia. But typically when we're seeing these patients, they've got a raging glomerulonephritis. It's not, we're not looking for microalbuminemia. So Pooja mentioned that UPCR was typically high, or there was a lot of protein typically. Does anybody have in their mind at what point, if you got a UPCR back, at what point you'd say, oh, I think this is glomerular disease as opposed to tubular disease?
Was it over 8?
It's even less, actually.
I would say 3, like 3 or 4, something like that.
Yeah, 3.5 to 4. So if it's over 4, it's probably not tubular. It's probably a combination of glomerular and tubular. But if it's sort of 8 to 12, it's the glomerulus is just an open sieve. The protein's just flooding out.
So why, if it's tubular, you shouldn't be getting protein loss? Are we doing tubular plus glomerular?
Well, because tiny little bits of protein will move through those filtration membranes, and then we rely on the tubules to absorb, proximal tubules to absorb them. So if the proximal tubule's not working, we will get low-grade proteinuria.
Yeah.
And the other thing that happens is we rarely have a pure glomerulonephritis or a pure tubulopathy because they're so interconnected. So if you get a tubulopathy, you get kind of obstruction, you get backup of pressure into the glomerulus, and then you've got a glomerular nephropathy as well.
Yeah. So less than 4, over 4, between 4 and 8 could be just mild glomerular disease or tubulopathy, or both.
I wouldn't say mild glomerular disease. I'd say if it's over 4, we've got glomerular disease we need to look into pretty urgently, because it will then cause a tubulopathy. That's most
Anna?
Yeah.
When Braun said about, I think there used to be a test, or there's a test for urine, I had a vision of the SSA test, sulfosalicylic acid.
I used to know about that.
Is that a thing?
Yeah, it is, but I
Okay.
don't remember about it.
I also don't think I've done it, but that for some reason that just came straight to my mind when she said something you could do in-house.
Yeah.
Having to do with diagnosing protein in urine.
Yeah. Can one of the membership candidates look into that and let us know?
Yeah.
Thanks.
Okay.
Oh, sorry, I've not written down the categories. So what sort of glomerular disease would we see most commonly?
Like, do you mean primary versus secondary? Is that what you're?
No, I was thinking more
Immune
like
mediated?
underlying causes of glomerular disease.
So you have immune mediated versus anything, any disease process can actually lead to glomerulopathy.
Yeah, absolutely. So glomerulopathies are divided into immune complex glomerular nephropathies, non-immune complex glomerular nephropathies, and amyloidosis, essentially. So what sort of diseases would we see immune complex glomerular nephropathy forming?
Oh my gosh.
Like, would IMHA be one because antigen antibody complex?
Yep.
Could we stretch it to pyometra?
Yeah, absolutely. It's a really, it's a bit of a trick question because it's pretty much any cause of increased antigen or increased antibody will result in increased immune complex. And then if you've got immune complexes, so antibody antigen complexes, they're big structures, they get blocked in vessels. And particularly when we're dealing with IgM mediated or IgA mediated responses, they're big complexes, they get stuck and they cause glomerular damage. Or they can cause damage uveitis. What other areas of the body do we get a really sort of dense capillary bed that immune complexes might get stuck in?
The gut.
Could do, yeah.
The
We
lung?
don't typically see clinical signs associated with that though.
Lungs, yeah.
We said uveitis. One other organ that kind of gets slammed with immune complexes.
Lung?
Yes, good. Tiny little capillaries that branch right out, and a function of that organ is dependent on those capillaries being open. So eye, lung, and kidneys are the three organs that are vulnerable to immune complex deposition. We see sometimes with immune-mediated diseases, periphery, you know, in cats with systemic calicivirus and stuff, they get toe pad sloughing. We get mucocutaneous junction erosions and stuff like that. So it's where all the capillaries are just coming to their narrowest point, and we're getting complexes of immune complexes being deposited in those spaces and blocking those vessels.
Do you get characteristic symptoms of the lung immune complex deposition?
Usually causes like VQ mismatch.
Oh, right. So it might be dyspnea or a tachypnea.
Yes.
Just
But also, because immune complexes are pro-inflammatory, we also often end up with non-cardiogenic pulmonary edema. So it's one of the mechanisms for ARDS, for acute respiratory distress syndrome. So what, in terms of what diseases can cause that, for sure, IMHA, pyometra, any kind of acute infection, we would probably expect to see some proteinuria. But it's actually the more long-term infections that cause the most damage because of their chronicity and the kind of the mechanisms that the kidney uses to respond to those insults. So really, there's very limited options for the kidney. We're going to get an inflammatory cell infiltrate, and then we're going to get fibrosis, and then we're going to get a reduction in the ability of the blood to flow and the ability of the tubule to function. So what are some really chronic diseases that we fortunately don't see very often anymore?
Would viruses do it, like in cats? FIP,
Yep.
FIP, FIV, FELV.
Yep, for sure.
Heartworm disease.
Heartworm, that's the big one. Yep. What about tick-borne diseases? Do we have any in Australia?
Ehrlichia,
Yeah.
Ehrlichia? We do, yeah.
Babesia, maybe.
Definitely. And then the mycoplasmal infections in cats. So anything that's got increased antigen over a really long time will cause, sort of, by the time you've detected it, it's serious. What about, are there any diseases that will cause direct antibody deposition in the kidney? Like, any sort of autoimmune diseases that would target the kidney specifically? It's a tricky question. It's probably a fellowship level question. So this,
I was going to say, but that would be like primary glomerular when it's attacking the kidney itself. Like,
it's primary. Yeah, exactly. Yeah. So if we sort of think about the same way we think about IMHA, where it's primary IMHA if there's autoantibodies against the red cells, or it's secondary IMHA if the red cells are being destroyed because they've got mycoplasma in them, for example. If we think about the kidney the same way, you can have secondary immune complex glomerulonephritis, or you can have primary. And primary is, there's a couple of different mechanisms of it, but there's been, if we put the whiteboard back up again, most of the infectious disease ones, the immune complexes are getting lodged in the blood vessel, but the autoimmune ones are usually against either the basement membrane or the epithelial, or there's immune complex deposition on the epithelial side of this structure. So you can see if you've got a kidney biopsy, how your kind of way of approaching or managing these diseases might change. So if you've got immune complex deposition, you're going to be looking for a systemic disease if it's in the blood vessel. If you've got immune complex deposition in the basement membrane, you're probably going to look at immunosuppressing these patients, where that might be completely inappropriate in your cat with mycoplasma, for example. Make sense?
yes, but you can't really, like, kidney biopsy doesn't tell you that. You have to send it to US to do some very specific thing.
Yeah,
Or
that's
something.
what you should do with your kidney biopsies. If you're getting a kidney biopsy, you should be sending it to the US. You don't get enough information about anatomy from the tests that they run in Australia. And it's in my mind, it's a high risk procedure. If you're doing it, you should send it off. Because it's actually not very expensive over there. It's just the shipment that's annoying. You've got to do all the clearing and customs and stuff like that. So in the US, they do a variety of different stains, which are specific for the type of antibody and where they are. Now, this structure would require electron microscopy to see it appropriately, and that's only done over, in fact, I think they can do electron microscopy here, but they don't do the immune complex examination here. The consensus statement that came out in 2013 was very much histo, like how histopathology should be performed and reported for renal biopsies. I wouldn't necessarily recommend it's not recommended reading for membership level at all. But once you read it, you never send another kidney biopsy to a lab in Australia. You just don't get enough information. Okay. What about non-immune mediated causes?
I actually have a question with
Oh, yeah.
SLE, like would that be classified? Because SLE by definition is like two body systems involved.
Mhm.
Then does that become primary or secondary?
That's such a good question. So you'd need electron microscopy to determine that. So if you had, because in lupus, you've got an excess of antibodies. So we're going to have excess immune complex generation because we've got that imbalance of antibody and antigen. We're going to have increased antibodies. They're going to get deposited in the vessel. But we might also have a primary basement membrane targeted autoantibody. So you'd need to differentiate that. You'd need to have electron microscopy. Really, it's academic because you've got autoantibodies and you're going to immunosuppress that patient.
Yeah.
But really the big sort of significant differentiation is, do you need antibiotics or do you need immunosuppression, basically? What other non-immune complex forms are there?
Pyelonephritis?
I reckon that might be immune complex mediated. So most of the time pyelonephritis is ascending and it tends to impact the tubule, collecting duct, renal pelvis, collecting duct tubule, and then cause obstruction of the tubule and glomerular damage that way. So it's kind of inverted. But when it's hematogenous, it hits the glomerulus first, and then it will be immune complex deposition that causes the damage, I think, and it infiltrates some inflammatory cells and stuff. What about hypertension?
Oh, yeah.
Yeah. So what does hypertension do to the glomerulus? My whiteboard's very handy. Let's open it up again.
It'll constrict, won't it?
It will constrict. Yeah, exactly. So it's going to try really, really hard to protect the glomerulus from this hypertension. But if hypertension exceeds 170, 180, all of that pressure is going to get through to the glomerulus. It's going to cause damage to the endothelial lining, that really fragile barrier here. We're going to get bigger holes in that, which is going to cause what?
More protein loss.
Leaking.
More protein loss. Yeah, exactly. And then over time, so what happens if you've got bigger holes in the endothelium, but there's not actually bigger holes in the rest of it, is that the fluid accumulates in this subendothelial space. So that impacts both the Bowman's capsule, but also the mesangium, which is that connective tissue surrounding the endothelium, and the mesangial cells. And they're going to get annoyed and they're going to cause vasoconstriction to try and wall off that increase in pressure. And we're going to get fluid flooding into that mesangial space, which is going to put pressure on those capillaries from the outside. And then we're going to get increased glomerular pressure, aren't we, if the vessels are all being squashed? And we're going to get decreased filtrate because there's less blood able to get through there. So that causes ultimately fibrosis and sclerosis. And that will, if we've got decreased blood supply going through the glomerulus, we've got decreased blood supply going to the nephron, and the nephron will die. That's the most common cause of non-immune complex mediated glomerulopathy. And then the last one was amyloidosis. What do we know about amyloidosis?
Yeah, deposition of amyloid, which is, I think it's an acute phase protein.
Good.
Gets deposited in a few places, especially in Sharpei's.
And Siamese is the other one. Get it? Yeah. So there's a couple of sort of specific therapies for amyloidosis. So it's worth doing a biopsy to find out. And that's something that can be diagnosed in Australia. You don't need to send off for amyloidosis. But it's got a really distinctive appearance of the glomerulus. It's just all pink. It's just all hyaline, like proteinaceous material. And the vessels are so squashed. You can see them all really constricted. The trouble with amyloid, and you'd need to know it was amyloid before you went for a biopsy, is that because they're so fibrous, they're more likely to bleed.
Mm.
So the risk of biopsy with amyloidosis is much higher. So it makes me nervous if I've got a Siamese or a Sharpei. We're not going to biopsy the kidney, probably going to just wing it.
Yeah.
Yeah.
You can buy it, but if they're those two breeds, just assume that it's amyloid.
Yeah, exactly. Yeah, exactly right. And like sometimes the changes on ultrasound, like because it's a really fibrous process, there'll be hyperechogenicity and stuff. Often the liver's involved as well. So there's some hints that you might sort of go, don't stick needles in there.
And they might have other joint issues or whatever. I don't know if there's
Sharpeis in particular. Yeah. With Sharpeis always come with a longer history of stuff, whereas Siamese sometimes hide it. Okay, now that we're talking about winging it, and we've sort of talked about diagnosis, do we need to cover diagnosis anymore? Not really. UPCR and biopsy, they're the main things. Actually, we should say the consensus statement does have a good guideline for what tests you should do to rule out, if you're not going to biopsy, to rule out systemic inflammatory disease before you have a go with immunosuppressants.
Right. So just the most common, non-primary, most common secondary causes.
Exactly.
Right.
So that's open access, that consensus statement. It's a JVM 2013, and there's a paper on guidelines for immunosuppressive treatment in dogs with glomerular disease.
Anna, would you use CRP as a monitoring tool?
That's a really good question. I haven't seen any papers on the CRP levels with glomerular disease specifically, because some of the glomerular diseases aren't inflammatory. So it's like glomerular sclerosis and amyloidosis don't cause an inflammatory response. But I don't know if it would differentiate between, like, for example, a septicemia and pyelonephritis, hematogenous pyelonephritis versus lupus, you know? So it might be good for monitoring response to therapy, but not so much for actually diagnosing. Okay, so the consensus statement says there's 3 kind of things you should be considering in your management of glomerulonephritis. 1, treat the underlying disease. So diagnose and treat if possible to decrease ongoing damage to the glomerulus. Number 2 is work as hard as you can to decrease proteinuria, because that will save the rest of the nephron and kidney. And number 3, manage the uremia. And that's just chronic kidney disease management. It's exactly the same as what we've seen in the other chapters. So how are we going to say we've done all of the infectious disease testing, they've all come back negative, we can't find any other evidence of autoimmune disease, but we've still got high grade proteinuria, and we've done a biopsy and it said that there's immune complex deposition in the glomerular capillaries, so consistent with systemic inflammatory disease. What immunosuppressants are we going to choose?
In this specific scenario, would you actually want to use ACE inhibitor first to decrease the proteinuria, see the response, and then do immunosuppression, or would you just jump to both?
Good question. So in terms of like the way that I think about this, treat the underlying disease, manage the proteinuria, manage the CKD. So as far as treating the underlying disease, the proteinuria we'll talk about separately, but treating the underlying disease, we're either going to treat an infection if it's there, or we're going to immunosuppress this patient if we know that we're dealing with immune complex deposition. So let's talk about treating the underlying disease first, and then we'll talk about the proteinuria management, if that's all right, just because that came first in the list.
Probably don't want pred then, because you don't want to contribute to hypertension.
Good.
Maybe azathioprine or cyclosporin.
Good. Both good options. Sorry, what was that one?
What about mycophenolate?
Mycophenolate's a really good option. Yeah. So the consensus statement says cyclosporin and mycophenolate are the best options. Cyclosporin in humans is associated with renal blood flow changes, but they still use it in transplant patients and things like that. So we're going to be monitoring azotemia levels. If there's a sudden spike in creatinine after starting cyclosporin, then you'd switch.
Right.
I don't know why they don't use azathioprine as their kind of first line recommendations, but they've said one of the two of them.
Is it because it takes longer? Like it takes 14 days to come into effect? Or is that not a thing really?
No, so that's what everyone says, 14 days. And there's no studies that say that. And somebody once made me actually do a literature search and demonstrate, because I said, it takes 14 days, and they were like, show me. And there's evidence of effect after 5 days. It's quite similar to cyclosporin and any of the other drugs that are working on the cytokines and decreasing immune complexes that way. But yeah, I don't know why, because obviously there's contraindications if you've got liver disease, but not kidney disease. So I don't know why. There's another reason why corticosteroids might just not necessarily be contraindicated, but just make your monitoring a little bit harder.
Because it's going to change USG, because it's going to cause ADH insensitivity.
It will, exactly, yep. And there's one more thing. There might be more than one, actually, because you've come up with 2 that I hadn't thought of. So we're going to have fluid retention that's going to exacerbate hypertension. We're going to have decreased USG. Has anybody ever done a UPCR in a dog with Cushing's? Or a dog on exogenous prednisolone? They've all got proteinuria.
Wow.
So it actually exacerbates proteinuria, and it doesn't, in all the biopsy results and stuff, doesn't cause perpetuation of renal disease. It's just a reflection of increased tubular flow, they think. But if you're monitoring proteinuria, you might be actually improving your proteinuria with the immunosuppression, but it's still going to look the same on paper because the cortisone's causing it. So the consensus statement does say you can use corticosteroids short term, but usually just to initiate treatment, and then you should look at weaning them after 2 weeks to a month for that reason. So what about, and that's the consensus statement has quite good guidelines on when to use immunosuppressants, and you want to have the breed and age that's inconsistent with familial glomerular nephropathies or amyloidosis. So if you haven't got a biopsy, you don't want to be putting a Sharpay on mycophenolate because it's not immune mediated. All right, what about treating proteinuria? What would we use as a first line?
ACE inhibitor.
Good. Yeah, that's the recommended first line treatment for proteinuria. What about if it doesn't make enough of a difference? We've still got a higher grade proteinuria on ACE inhibitor. What would we add in?
Telmisartan.
Telmisartan, did you say?
Telmisartan.
Yes, perfect. Yep. What is telmisartan?
It's an ARB.
Good. Which stands for?
Angiotensin receptor blocker.
Good. Excellent. Yeah, exactly. So that's going to work quite well on our hypertension, which most dogs with glomerulonephritis have, as well as the proteinuria. And you can use both of them together. And there's a couple of safety studies. Edinger says there's not enough safety data, but there's a couple of safety studies now that show that they work quite well together without increased risk. Obviously, you're dropping the blood pressure more significantly than you would be with just one agent. So caution, and we usually introduce one at a time. But yeah, fine to use all. What about if you've still got hypertension after introducing your ACE inhibitor and your ARB?
What are you using?
Can you add calcium channel blocker?
Yeah, good. Yeah, exactly. So in that situation, we'd add in amlodipine because that hypertension is going to injure the glomerulus more.
Anna,
Yeah.
is it okay to use, say you have a cat and you wanted to use the telmisartan as the first line drug? Is that allowed
Yeah.
in the
for sure.
rules? Okay.
Yeah, in the rules. Yeah.
In the rules.
Yeah, definitely.
Sometimes just for ease of administration, even I think some people choose it first because of the formulation.
So there's more and more evidence that the ARBs are better with proteinuria. So this consensus statement is 2013. When that came out, we didn't have access in Australia to telmisartan. So we're getting more and more data now to suggest that. And I like, whilst we should follow the consensus statement guidelines, I actually think there's an argument for using telmisartan as a first line now. All right. Last thing, what are some of the complications of glomerulonephritis? Glomerulonephropathies, protein-losing nephropathies.
Hypercoagulability.
Yes, I love that one. Thanks.
Of course you do.
Yeah, that's the one I was like, it's the only one I want to talk about. We've got
coagulation cascade.
Yes, we can do that again if anyone wants to revise it.
No, it's okay today.
What's the cause of hypercoagulability in
Loss of antithrombin.
Yes, good.
3.
Yes, we don't say the 3 anymore apparently.
Oh, okay, sorry.
Yeah. So I started a PhD in hypercoagulability. Didn't finish, so never published anything. But I used to just watch dogs' clots form in a spectrometer. So we shine a light through plasma, activate clot formation in dogs with different diseases, and as soon as a clot forms, the light stops going through, and you can measure how much light's getting through on the other side. So you get this really nice curve of like there's light forming, no light. Dogs with protein-losing nephropathies and enteropathies, both of which lose antithrombin and lose the inhibitors of coagulation, their clots form faster than I can get their blood in the machine. They're so amplified as far as how fast they clot. So it's really interesting kind of picture in my head of like what's going on in their bodies when I see a dog with a protein-losing pathology. So they've still got pretty good fibrinolysis. They've still got normal factor levels and stuff, but they've got decreases in their endogenous anticoagulants, and therefore there's no inhibition to clots forming. They just form all over the place. What happens if a clot forms in a glomerulus?
You will get probably fibrosis and loss of that nephron.
Yeah, absolutely. And because we've got inflammation locally in a lot of these patients as well, we've got endothelial damage, we've got inflammation, we've got loss of endogenous anticoagulants, we've got the kind of whole Virchow's triad of decreased flow of blood as well, to, I guess, contribute to increased clot formation, specifically in the glomerulus, and that will perpetuate the renal disease. How would we manage that?
With clopidogrel.
Yeah, perfect. So we want to, by inhibiting platelets, we inhibit that really fast clot formation and really early clot formation. So the 2 agents that are in the consensus statement are aspirin and clopidogrel. Both have a lot of evidence for them. Clopidogrel has more evidence and a wider safety margin than aspirin. So that would be my recommendation.
So would you put them on this from get-go? Like the minute you've decided it's a glomerular, would you put them on these drugs straight away, as in clopidogrel?
I would, yeah. Once I've worked out that they don't have heartworm, that they need to have like removed from their vein and I anticoagulate them and make them exsanguinate. Yes, I would for sure.
Okay.
I'm pretty proactive with anticoagulants, so
Mhm.
the surgeons don't like it.
So Shar-Pays could also benefit from clopidogrel too then.
That's a good question. If they're losing protein, then yes. Yeah. So the key thing there is if they've got protein losing nephropathy and their albumin's a little bit low, then you can bet that they're antithrombin flow.
Mm,
And in that case they would. But if they're not hypoproteinemic, then I probably wouldn't.
okay.
Yeah. All right. We're gonna wrap up. Thanks, guys.
Thank
Thank
you.
you.
Nice to see you all. Oh, it's urolithiasis next fortnight.
Okay.
Onto lower
you.
urinary tract.
Bye.
Thanks, Andy.
Bye.
Good day.
Thank you.
Bye.
Bye.